Hello, guys. So today I have another case for you. So let's start our case. This is a 59-year-old male, and patient has history of diverticulosis, hypertension, BPH, pancreatic cyst, and here is the important part: multiple substance use disorder, including alcohol, heroin, and cocaine. And patient was found to be unresponsive on his chair in his apartment, and he was found by his neighbor. And EMS went to his apartment, and patient was given some Narcan. Patient was showing some minimal improvement, became partially responsive at that time, and the EMS found that patient had some crack pipe around him, which is cocaine. So our patient came to the ED. In the ED, patient was found to be like tired and sleepy, but was easily arousable. He was answering the questions at that time. He endorsed some generalized abdominal pain, but it was mild. And otherwise, patient was saying, "I am okay." He was just saying he tried cocaine first time. In the ED, vitals showed pretty much unremarkable findings other than mild elevated blood pressure at 170 over 106. And physical exam was done that showed our patient was lying on his bed, somnolent, drowsy, but patient was easily arousable with like verbal stimuli. Otherwise, patient was AO times 3. On respiratory exam was positive for bilateral rhonchi. And on abdominal exam, patient was kind of mildly tender on the all over abdomen, but it was not like surgical abdomen. There was no rebound or guarding. Otherwise, on further examination showed that patient has some proximal lower extremity tenderness on palpation, mostly on quadriceps region, bilaterally. So in the ED, patient was done some lab. Lab was pretty much unremarkable. CBC showed elevated white count with left shift, and also there was like with hemoglobin 11 and MCV being 94. There was normocytic anemia. Nucleated RBC was mildly elevated at zero point 0.3. BMP showed some borderline elevated sodium with borderline elevated potassium at 5.5. Chloride was 103. Bicarb was low at 13, and gap was elevated at 28, with creatinine being 2.9 with baseline of 1.3. So our patient was having some AK on CKD, and liver function tests showed that elevated transaminases, AST and ALT being around 150s, but alkphos and total bilirubin was normal. So our patient didn't have any cholestatic picture, just elevated transaminases. Given patient was found to be unresponsive, total creatinine kinase was done, which was mildly elevated initially at like 600-ish, and lactic acid was done given patient was having some abdominal pain and leukocytosis. So lactic acid was done, and it was like severely elevated at 13, and the blood gas VBG showed pH of 7.01 with severe acidosis and PCO2 of being 54. So our patient VBG shows like blood gas shows severe acidosis with low bicarb, so this is metabolic acidosis, but there was no significant compensation on the PCO2. It was elevated, so we would expect it to be low for the compensation, but it was elevated, mildly elevated. So our patient was having metabolic acidosis on top of respiratory acidosis. There was no compensation, and UTOX was done and it was not surprisingly found positive for cocaine. So indeed, the imaging was done. Chest X-ray was like pretty much unremarkable, clear lungs. There was no cardiomegaly, no significant infiltration, no collapse. So given patient was found unresponsive, and our differential was like a seizure or like stroke. So head CT was done that showed pretty much negative, no mass, no bleeding, just some choroid plexus calcification, which is very common and benign, otherwise unremarkable. And next, CT abdomen pelvis was done, given our patient had abdominal pain, right? So, abdominal pain with elevated lactic acid. So there was concern for bowel ischemia or like pancreatitis or colitis. So we scanned the patient abdomen and pelvis, but we couldn't give any IV contrast given our patient was having AK on CKD. So CT abdomen pelvis was showing some right lower lobe infiltration. So here distended stomach, and there's some like cystic findings on the right kidney, and spleen looked okay, pancreas. So yeah, here is some other cystic findings on the left kidney. Pancreas looked okay, no peripancreatic fat stranding suggestive of pancreatitis. So otherwise bowels look okay, and there was no obstruction. It was pretty much negative other than some benign findings. Yes, and there was no like abscess, phlegmon, suggestive of some infectious process, and bladder was like full. Yes. So then, not surprisingly in ED, so to recap, our patient is like a middle-aged man, history of polysubstance use, was found to be unresponsive, and came to the ED, was found to be positive for cocaine, and patient was pretty much dehydrated, some leukocytosis, abdominal pain. So for the like sepsis, a patient was given sepsis with unknown source. Patient was given some ceftriaxone, vancomycin, and patient was given some IV fluids. Given patient was toxicated. So at this point, we were paged. We went to the ED for the admission. So in the ED, we saw the patient. The patient was pretty much how I told you until now. So our differences at that point, like patient didn't look bad himself, but his numbers was concerning, especially severe acidosis. So at this point, we admitted the patient and we continued the IV fluid regimen given patient was toxicated, and we followed up some labs in the evening of the admission, and it showed us some answers. So patient's transaminases bumped up to like 2800 and 2300 for AST and ALT. So this was showing some significant elevation, and total CK went up to like 32,000 from 500, as you remember. So at this point, we found out that also creatinine went up to 4. So our patient was having some rhabdomyolysis, some elevated AST-ALT. It was like muscle versus liver for AST and ALT, and for rhabdo, our patient was having some ATN. So we continued giving IV fluids. We did some frequent labs. So at this point, there was a teaching point for me. So our patient came into rhabdo, right? And initially it was 500. So it was very mild elevated. To be able to say it is rhabdo, so total CK should be 1000. But if we didn't like follow up the creatinine kinase at that night, we might have missed that patient was having rhabdo. The teaching point being, so this is the serum creatine kinase. So it peaks at day 1. So at 24 hours, it peaks. So if you suspect rhabdo, you should like continue trending it despite the initial CK normal or mild elevated. And also here, as you saw, our patient was having elevated AST and ALT, and it also shows there is a correlation between elevated creatine kinase with ALT and AST. So here you see this is ALT trending up day 1, day 2, and day 3. So it peaks at day 3 when patient is having rhabdo. So at that point, so our patient was having creatinine was trending up. First it was 2 point something, then it went up to 4. So we asked nephro, so what to do. Does the patient need any further management or treatment? Nephro just said that this is ATN because of rhabdo, just continue IV hydration, and this is the initiation phase, extension phase, just give some time. And we followed their recommendation, and we also asked GI. Like, I was very impressed by patients AST and ALT going up, that's significant, and we asked like if we should need to contact places for like liver transplantation. But like GI said that like continued IV hydration, this is probably cocaine-induced hepatotoxicity versus rhabdo-related transaminases. So at that time, our patient didn't have any bilirubin elevation or didn't have any elevated alk phos. So it was like rhabdo versus hepatotoxicity. But we were told to just continue IV hydration. And as you saw, as you will see, our transaminases would go down. So first I would like to talk to you about some follow-up labs. So for total creatine kinase, we said that like initial, so this is the day 1 first admission, initial total CK was mild elevated at 500, 600, then significantly went up at 22,000, and then kind of peaked at 37,000 on day 2-ish, and then went down and normalized with IV hydration. And our lactic acid initial was 13, and after IV hydration it went down. So this is 6 p.m. in the first day, then we continue follow on next day, 6 p.m.ish, it was 2.8 after IV hydration. So other labs, AST and ALT. So we said that this is like transaminases. So first initial like AST was 140, then next morning in 12 hours it went up to like 1900, then peaked at like 4400 on day 2ish, then it went down, and this was probably like combination of rhabdo related hepatotoxicity and rhabdo related transaminases and cocaine induced hepatotoxicity, but it normalized in 2 to 3 days. For creatinine, this is another teaching point. So patient came with creatinine of 2.9, then peaked at 7. So at that time, patient like these days had very low urine output, kind of having oliguria, and we called the nephrology at that time, if any need for dialysis, but nephro said that just give some more time. So normally in ATN we discharge patients in the like initiation and extension phase. So I didn't see improving creatinine before this patient, but this patient is a very good example that it's initiation and extension phase, then recovery phase, maintenance phase, and recovery phase. So this is a good graphic. So on ATN, on day 0, so the event happens, or in our patient it is the rhabdo. So there is some cell injury, it causing the like tubular obstruction, and GFR declines abruptly from 100. Then for a couple of days it continues to decline. On day 2 to 3 it becomes flat. There is like some pathophysiologic mechanisms that I don't know, and after a couple of days the epithelial cells recovers, and this is recovery phase, and RGFR starts to improve. And for the urine output wise, so initially this is oliguric phase, like our patient, then in the maintenance phase and recovery phase, patient started to be polyuric and doing a lot of urines, making a lot of urines. So this is pretty much it. Thank you for listening to me, and if you have any contribution, like positive feedback, please feel free to comment. I'm happy to read and improve myself. Thank you.